Everyone can turn on their videos, but people, it's up to choice.
Okay, I thought, okay, I thought you did that. I mean, that is my first understanding. Why would only 3 people, one person who's good looking and 2 other people who are like withering away in their 30s, have their?
I've already withered away, man. I heard you, so I withered.
Yeah. So I was wondering if we can have everyone's videos on. The reason I like this to happen is only because we want this to be better than the average rubbish CME that's held across India, where some big speakers are saying something and everybody else is feeling intimidated, so they turn their video off and they are attending only because either they are supposed to attend or because they want to listen but they don't want to be seen because they feel that they may be asked questions because they're visible. So a good thing is you can see the background of William there, completely useless white background. It's not fancy.
Wall. I'm not
exactly.
going to paint it for this.
Okay, good job. See there. And you can see my background. It's also pretty useless. But at least it has 2 colors, unlike William's boring wall. So it's nice to see each other. We know whom we are talking to. I mean, that's I have a connect with St. John's, which is beyond just a medical college. So I would first of all like to thank Betsy for doing this. Thank you, Betsy. Very kind of you. Means a lot to me. You may see me crying sometime during this discussion, only because you've done this emotional thing for me. The rest of you all, whenever you feel comfortable after you've finished doing your makeup or worn some clothes which are worthy of the video, it'll be nice to have your videos on. Superb. So just a couple of questions. In emergency medicine or in a hospital, what is our primary concern? Like, what's the first thing we do when we want to become doctors? What is the main purpose of being doctors? Anybody? Obviously, if people are not turning on their videos, can they at least turn on their audios, please? Don't make me cry. An emotional guy. Yeah, turn off your audio. Anyone say anything that you want to say in any language. Trust me, between 3 of us or 4 of us, we can speak 7 languages. So why do we, as doctors, what's our first duty? This is a general question. It's not an MCQ, and it doesn't, trust me, this answer to this question is not there in any textbook because it's common sense. I can ask my father who's not even clear 10 standard. He'll answer this. Okay, so I used to believe that our primary purpose in emergency medicine is to save lives. So I used to go saying, I'm here to save lives. And for most of my 3 years, that's what I kept doing, trying to save lives and thinking I was doing a great job. And each time there was a crowded department and patients died. And in St. John's emergency, virtually every day, sometimes you can have 3 patients dying. So it's not uncommon. And towards the end, I was like, I'm wasting my time. There are patients who have to save. There's somebody's dead. Okay, they're dead. Move on, save the other lives. Obviously, with a little bit of emotional maturity, which you tend to gain at different ages, and if you are in the presence of fantastic people like Shakuntala Murthy, you'll gain it earlier rather than later. So I then began to learn that my job is not just as simple as treating patients, because that's something that AI can do after some time. Our job is to comfort them. That's something AI can't do, at least not now. It then means that once the patient is dead, you can't help the patient because you've set your goal as treat the patient, but the patient is dead. There's nothing to treat. Then your extended goal is to treat the family. And it doesn't take much time, trust me. The big question is, why should we do this? Why should you spend time on a busy shift trying to declare death in a very, very organized manner and waste your energy and time on it when you have other things to do, which could also mean going and getting a cigarette? The reason is simple. Number one reason, because now we are redefining our care as just making people feel comfortable. That's one. Number two, if they are comfortable, indirectly will mean you are comfortable. Because uncomfortable, disappointed, and angry relatives means 2 things. Means they're going to be angry and violent towards you. If they're not going to do that, they're going to come back and complain and sometimes go in for litigations. All this can be avoided by just being a good human being. Forget about doctor, being a good human being. Spend some energy. Let's declare death because that's the least they deserve. That's all I have to say. And I know that Anne's got something more solid to say apart from just this emotional drama that I'm doing. She has more reasons why we need to do this. how we need to do this, and what impact it makes, that it's definitely worth our time. On that note, I'd like you all to unmute your mic and just give me a round of applause. That's the least you can do, guys. I've spoken so well. I'm tearing up. Even William,
it's just us.
normally always laughs, but this time he's crying. William, thank you, man.
It's just us. No, someone's leaving, dude. Someone left. Can you believe that?
That's because they saw.
I think they were very emotionally.
For a cry or something. Let's assume.
They were very emotionally affected by your speech, Murtaza. Okay, Murtaza stuck, right?
Yeah, another thing is a lot of them are like bonders, so they might be still working, and then
I know they're not trying actually. It's fine.
Yeah, they're trying to get some time and like log in and join us. Yeah. So.
This wasn't the ideal date for everyone. They all wanted tomorrow, but tomorrow I start night duties, so I was being selfish.
Also India Pakistan is there. So yeah, nice.
Oh yeah, more important.
Yeah. Okay.
Okay, just a minute. Shall I start then?
Yeah, over to you, Anne. Yeah.
Okay. Clothes. Yeah, all right. So breaking bad news. Like Murtaza said, there's a certain amount of respect and dignity you should show towards someone who's passed away and their family. So what can you do? Because again, this is not an algorithm, nor is this a flowchart that you can follow. It's just like a guideline. It's just like a few pointers which you can pick up and then put to your daily practice, because you will be declaring, if not death, you will be declaring bad news to someone almost on the daily basis. So it's again just reminding you guys, it's not an algorithm or a flowchart. Right. So as per MBBS and in even internship, we've been taught about our clinics and our academics, and all of this has been monitored by our seniors and by our faculty members, where you're taught about your signs and symptoms, and then treatment management, and how you would take care of a patient, and when you could discharge or refer a patient to another place. And you'd also be taught about, what after MBBS, what after MD, what after MS. And these are things which have a curriculum, which have a syllabus, and when you have something so solid to pick on, it's easy to grasp onto it. And learning something such as breaking bad news or certain soft skills, this is an art. It's something that will set you apart from other doctors who just go by these traditional medical tasks. So today we're dealing with bad news and death. So why is it important? Now, it's important for you as well as for the family, because one, put yourself in the place of the family member. To deal with death is, first of all, such a horrible, traumatic experience. And then to receive such news, or to be delivered such news in a very cold, in a very indifferent manner, is even more traumatic. And in fact, 20% of patient relatives have experienced post-traumatic stress disorder because of these sudden deaths and unexpected deaths. For you, it's very important, especially if you've been taking care of a patient and you see that patient deteriorate, and you know that patient's not going to come through. By sitting down with the family, speaking to them, helping them understand the patient's condition, it sort of helps you get closure from such a difficult case or a difficult patient, and also prevents the ED as well as prevents the department or your nurse and the other staff who've been taking care of such patients or who've seen such patients throughout the career. It prevents trauma for them as well. Right? So it reduces the stress and the burnout that the emergency or your bond staff experiences. All right, because once you learn how to calm them down, or to even just respect their emotions and their status at that point of time, would help reduce the stress and the worry that everyone experiences when you're breaking that news to the family. All right, so this is a very simple mnemonic, which I wish I knew much earlier. It's from Tintin Ali, and Murtaza introduced me to it. So it's grieving with a space in between. The space is important. So it's G for gather, R for resources, I for identifying, E for educating, V for verifying. The space, you have to give them some space, and then I for inquiring them if they need anything else. N for, I'll explain this to you, nuts and bolts. And G is for giving them extra support or comfort. So we'll go through each of these points in the mnemonic in the coming slides. Right. So gathering, one is you would want to do this, breaking the news of the death of a loved one in a quiet place. So you need an environment, probably keep a setting separate from the hospital, maybe even your office or your cabin, where it's a little bit open, but at the same time, the family gets that privacy to grieve. And if you have just one family member attending with the patient, try to get another family member or even a friend or a neighbor. Of course, there will be someone else there. So try to get a few people so that when you break this news, it would be easier on them. And, you know, being alone and receiving such news versus having someone, a loved one close to you and receiving such news is much different, and is definitely very beneficial for you and for them. Next is your resources, which is what I said, friends, family. If you have, most of your work in centers run by nuns and by religious congregations, right? So having one of them, because religion, people are still very strongly connected to faith. And being connected to faith helps. It's sort of like something they can grip onto or grasp onto at this moment when they are really hurt or at loss. So having that would be very helpful. And if you're not good at the language, like some of y'all said, y'all are in centers where y'all don't speak the language very well yet, and y'all can speak a certain amount of it, but not very well. It's good to have someone who has a very strong grasp of the language. So having someone who you trust, who can deliver the information exactly how you're saying it in the language that the family members understand, is very useful. So resources, this is about that, and identifying yourself. So this is very important, and I'll show you in a video coming up why it's very important to identify yourself as the doctor who's treating the patient. It's important to identify the patient by name, and to understand how much the family knows about the patient's condition. Because if the family thinks he was all right and you haven't identified this, and then you suddenly break the news to them, it's going to come as a huge shock to them. So it's very important to identify how aware they are of the condition of the patient, or how aware they are that the patient has possibly expired, or there's something that they're not expecting. All right. Right. So once you've gathered, sorry.
Are you in a flow that you would not like to be interrupted, or you don't mind an anecdote?
I'd add. No problem.
Oh, no problem for which one? The anecdote. Okay, fine. So, yeah. So this is interesting. I want you all to pay attention, and this actually happened. It's the most awkward thing ever. As Anne has just said, identify yourself. One, that they need to know who you are. You're the doctor in charge or whatever you are. And second, identify the patient's name and the relative. It's happened in the emergency department. We had a 55-year-old male who had an MI and came in with his wife. And obviously he had arrested already and CPR was unsuccessful. So I had to declare him dead. So I took his wife to a cabin, explained the whole thing, and it was a busy shift. There were 2 intubations waiting, and I held them with the junior doctor saying, I'm going to quickly declare death to this man's wife. She's grieving. Went in there, spent about 8-10 minutes declaring death. And then finally and she cried a lot. I know I was giving her paperwork sorted. Sorry?
I think there was a small lag over there.
Okay, yeah. So then I asked her. She grieved a lot. She was crying. I didn't stop her, and then there was so much pressure on me because patients were waiting. I did all of this, and I said, okay, you know what? We need to crack on with, let's say, the paperwork. Would you be willing to sign? And she said, no, I won't. I won't be able to sign anything. I said, why? She's like, actually, I'm not his wife. We are office colleagues. We were just spending the evening and last night together. I was like, oh shit, I got this completely wrong. And the problem was not just in getting it wrong, it was also because it was a waste of time. And I spent so much energy when I could have saved other patients, declaring death in absolute detail to his whatever friend or whatever you want to call it. So then we had to tell the MSW to call the family. The wife came back and had to go through the same thing again. Again, she was crying, and so literally 25 minutes spent on a shift when there were other patients dying, only because I just didn't ask what the relationship was. So just a thought. It's always nice to just blindly follow this checklist. She needed to be declared. Just that I would have not done anything too differently. I just would have spent lesser time telling her this because I needed the wife, or I would have said it to both of them or the entire family at one time. So yeah, that's a true story.
Would have been awkward if you're declaring it to both of them.
Yeah, so that's something for them to figure out on a busy shift. I'd say, you know what, you all figure out your stuff. But yeah, at least I would have spent less time, given her less time, and given the wife more time.
True. Right. So that's exactly why you would want to identify yourself and identify the family members also. So the next thing is, once you've gathered all of this information and you've gathered their identity and you've understood who you're speaking to, you're going to start educating them in the events. And by this, I don't mean you immediately say, you know, the patient has passed away or the patient has expired despite our best efforts. You're going to, you would want to gather, including this, you'd also want to gather a bit of history of what happened during that day. As in, were they unwell or were they completely okay? Since how long were they, you know, gasping for breath, and since how long were they unconscious? I mean, you'd get this information just when the patient is rolled in, of course. So you use this information to build up as to the fact that you're not bringing very good news to them. Or you using, you know, you're telling them, look, this patient was unconscious for so long. You yourself told me he wasn't breathing for this long. And you're going to slowly build it up to show that I'm not bringing you very good news. I'm not, you know, it's not something that's looking very positive. So, and then it's basically like a warning shot, or you'd be like, I'm very sorry to say that, you know, he has expired or he has passed away. Now, when you're saying the words, when you're trying to declare a death, be very clear about it. Use words like dead or died or he has passed away. Don't use words like he is gone or he's critical, um, or there was nothing we could do for him. Try to be very, I know it's very scary to use these words because you feel like you don't know what to expect from their side immediately when you say the word dead or he's died or he's expired. But it is very important to use these words because it clears a lot of confusion from their side. Because when you use other words, they're still clinging on to a hope that, you know, there's something that can be done. But using such words, these are words that are final, that are absolute. So it sinks in. Of course, they may react badly. It's not 100% thing that they're not going to react badly, but they may. But at least it's an absolute word, and you know, you're not trying to compromise, or you're not trying to negotiate some sort of care for the patient. All right. So at this point, you convey the death, and you express your condolences, and you immediately give them some space, or you give it a pause. Don't immediately jump to like, what's next? What are we going to do next? Does he need a postmortem? How are you going to take care of the body? Don't go to it. Just give them space to grieve. I think the best example here would be trying to put yourself in their shoes. This is empathy. Don't be sympathetic, try to be very empathetic about it. Put yourself in their shoes. You need some time to accept the fact that someone in your family or someone you have seen your entire life is now no longer with you, and not going to be with you in the future. So um, give them that space. If they're still alone, try to see if you can bring some form of emotional support. Ask them if you can call someone over to help. It doesn't need to be just family, even friends, or have someone with them at all times during that point of time. Okay. And you ask them further questions, like, so you at this point you've been speaking, and you've been giving them, the information, the events, the news of the death, and you've said, okay, now I'm giving you some space. You're giving them that space, that time to process this whole news. But at the same time, there's 1,000 thoughts that are running through their brain, and some of which they will not express, or which they will not verbalize. And you need to be the one who makes it okay for them to ask such questions. So always ask them if there's anything that you can do or anything that they want you to answer. And when they ask such questions, answer them clearly. If you don't know the answer, especially since you're in your bond and you may not know the certain procedures with how to deal with certain deaths and how to deal with certain proceedings, always say that you'll call in your senior and you will make sure that this doubt of theirs is answered. Don't say that, yeah, I will do this. That will put you into a lot of trouble. Okay, it's very important that if you do not know how to manage certain dealings with the whole death certificates and processing of a dead body, or what documents are needed for any civil court cases or anything like that, please, if you don't have the help of a senior at your bond center, at least ask the nun or the person who's managing the bond center, because they'll definitely have an idea, and it's something that you should not take upon your head. And I stress upon this extremely because I was in a place where I was writing death certificates left, right, and center. And I'm sure that many of the seniors will just shake their heads when I tell them that I have written causes of death as septic shock, or I've written cardiopulmonary arrest because my senior has told me to, and I've not questioned it further. And these are things which can get you into a lot of legal problems. So ask them their doubts and make sure you answer their doubts. And if you don't know, ask your senior or ask someone who knows about it. All right. Then coming to nuts and bolts. Okay, so organ donation, and yeah, organ donation is maybe something that's a little difficult in the Indian rural setting. I don't know if any of your centers do have any ties with tertiary hospitals that take care of organ donation, but if you all do, then maybe you can look into it. I'm not so sure, and I'm not very familiar with this, so I'll ask Murtuza and William to talk a bit more about this. But other than this, uh, after you've given them the space, you've answered their questions, now you need to ask them, what now? How do you want to proceed? Do you want to take the body home, or do you want to keep the body in the mortuary? And of course, the personal belongings of the patient have to go back to the family. And you should make sure that this is something that is taken good care of, because you don't want issues where they're like, this is missing from my family member's person. And so that's something which is very important. So because it might not be very valuable, but for the family it could be very dear to them. Any small personal thing also, it should be taken care of, maybe documented, like the nurses can document. That's what the emergency does in St. John's. They document what and all they take off the person's body, and they put it into a plastic bag, seal it down, and then give that to the family members. So this is something which you all may find useful. So that's basically with nuts and bolts. And yes, please don't don't not agree to allow the family members to see the body, because again, empathy, show some empathy and see what they would feel like. They'd want to see, you would want to see a family member if they've passed away recently, right? If it's a shock, especially to you. So use that bit of empathy and allow them to offer that opportunity to them to see the body, maybe in small groups, not a large group, because that again can create a lot of issues for you at your hospital. Right. Now, this is important. Give the family your name and contact information. Maybe you can offer the hospital number, because again, this is another issue which I faced with Bond, is when you give your personal number, it gets circulated around through family members, and then you'll start getting calls in the middle of the night for certain things, and people will call you asking you to come to their house and treat the patient at the house, and these are things which are a little dangerous. So I would suggest going with offering, you can offer your name and you can say you're always at this hospital, and if they want to come to the hospital and meet you, they're free to do so. And contact information, there's always a hospital number which they can contact, and the hospital can put you in touch with them. And giving this information, you can say that even if you have questions later on, even if you have any doubts later on, you can use this information, or you can come back to the hospital and you can get these clarified with us. And again, show some sympathy there, and show how sorry you are for what's happened, because a little extra emotion here will not go wrong. Because if you're seen, even if you feel like you're showing emotion, and if you're seen cold and indifferent to the family, it's it's really not a good thing, especially at a time like this. Whereas if you're putting out that extra emotion and the family with sees that emotion coming from you, it's sort of like a comfort for them. So do offer your like condolences, and show a bit of grief from your side as well, that uh, there was nothing that could be done for the patient. All right. Right. So right, so your own emotional responses, try to see, I mean, this is all again from learning. There's no number of PPTs that will like help you learn this 100%. But try to be, see, if you put empathy into your everyday work with every patient that you see, even if it's a normal patient who's come with acute gastritis, showing that bit of empathy will go a long way. Because when you really need to show that communication technique, that empathetic communication technique, it will come out naturally, and not something that you're forcing out of your mouth, not something that looks like you're just trying to um placate the family. It won't look odd, it won't look forced. And again, I can't stress enough about this. Try to be very accurate and very complete about the information that you're delivering. Don't try to evade certain informations. Don't try to, hide certain things. Give the complete information that you have, because you'll never know when such information may be caught by the family members or by some neighbor or by some bystander and delivered to them later, and that's really bad. If the information is coming directly from you, it's different from that information making a loop around, especially in a small town, in bond centers, making loops and gossips and coming back to the family through another person. It makes it very different, and the outcome also won't be very nice for you guys. So try to be very confident and just speak clearly, speak slowly, and give them that information. All right. So, Murtaza, William, do you all want to add anything at this moment?
William, I'd like you to add something, man, please. I'm
So
waiting
I
to hear
think,
your voice.
okay, cool. If you can, and if you don't mind, if you go back to the nuts and bolts slide, please. So
Sure.
from my personal experience, I disagree with a little bit of it. I know I'm going against my Bible of Tintinelli, but
Yeah.
when you're declaring death and when you're expressing that sentiment towards the family at the
Right.
first time when you're actually breaking the news, I would stay away from this conversation, no matter how busy you are. And this
Right.
would be a conversation which I have the second time I touch base with them. So the first time I
Okay.
want to go and I just want to break the news saying that, listen, Mr. X has died and he's passed away. And you
Right.
let them grieve, you let them see the body. As again, the other thing which we need to see, and especially in busy centers, is to make sure that the body is in a respectable position for viewing. You don't want
Right.
them to be splattered in blood, because that is their last image that they're going to see of them in the hospital, so to speak. So you don't want a scarring image for a child to see their parents, for instance. So make sure that they are respectable, and then they go and see. Once they've
Right.
done that, once they've had some time, then I would, talk about the other practical aspects of the nuts and bolts. Because, when you're breaking news, you don't want to be talking about, we found his genes. It's
Yeah.
very random, and you don't want to
Yeah.
be asking for donate or organ donations as well, because it looks very
Yeah.
predatory at that time.
Yeah.
So because you're looking like, listen, mera ho gaya, I've declared, but one body will really do us wonders. So it doesn't add up. So I would say that you stick to breaking the bad news, giving them time to spend with the patient, so that they get their closure. And once that's done, then you establish, or maybe get a second person, so that it's not you. Get a good cop bad cop routine going on. Get a nurse to go there, get another doctor to go there, and then they are the person asking for the belongings and the donation,
Yeah.
so that you become that chap who goes and empathizes with them all the time.
Right. Yeah.
Cool. That's all from me.
Murtaza?
No, I'm just going to take a few moments after Spot William has said, just to go in. Wow. No, I like the idea. This good cop, bad cop. I never thought about it that way, but I think it's not a bad idea, to be honest. The only thing I can add, like you said, involve nurses, especially the senior nurses. They know the game. They exude more confidence than most of us. So bring them in early into this discussion. And the more times you do it, the routine is set. The nurse knows what you're going to say. You know what the nurse is going to take over doing. It's nice to involve them early. Do not underestimate nurses in the bond center and otherwise. Never. I would never do that.
Yeah. Okay. So now going ahead with the case scenario, uh, I switch off my video because I'm very conscious of how I look when I speak. Anyway, so there's a 19-year-old student,
Only when you speak,
Arjuna.
is it?
Yeah, only when I speak. 19-year-old student, Arjuna, she's brought in by an ambulance having been knocked off her bike. Despite full resuscitation attempts, there was no return of spontaneous circulation. So you and your team have decided that there is no point of resuscitating her further. There is no benefit, and she was pronounced dead by your team. Now the girl's mother, Mrs. Annamma, has just arrived in the department and doesn't know what has happened. All right. So this is a case scenario, and we've made a small skit about it. Please forgive me for the quality of the video and the amount of noise there is in the background. This was actually shot in the ER at a very busy shift. So I hope y'all can hear it. Just put your the volume at full when y'all are listening. Let me increase the volume here. Right. I've been increasing the volume on my tab for my earphones instead of increasing the video volume. Okay.
Wow, that's a good
All
job.
right.
Really good job. I mean, I think you've covered, like, it's very, very good teaching thing. In fact, if you don't mind, I'm going to borrow this from you for my future teaching sessions. I'll give you all
course,
credit.
okay.
It's all money, but this is good. It's almost perfect the way I would have imagined. Thank you.
Right. Okay. So now comes the uncomfortable part for the rest of y'all, where we've been speaking all this time. Now y'all need to point out where we've gone wrong as per the whole grieving mnemonic. In this video, how each part of it you need to dissect and tell us where we've gone wrong. So I'd really like if everyone would switch on their videos. Okay, leave the videos, switch on your audios, and give
I
us
like how
some.
you input your expectations.
Alex, is there a way I can see the participants' names? For some reason, when I click on the 11 participants, I can't see their names. Or is
Oh,
something
I
wrong with
can.
me?
I
Okay, I
can.
can. I found a way. I found a way. So what we're going to do is you don't have to go completely in any order. Whatever first comes to your mind, each of you just say anything. Literally, you can say nice footwear also. It's okay. Anything that comes to your mind, but say something. All right. Okay. We'll start with Anne Marie. Anne Marie, say anything that you saw in this video, which was good, bad, questionable.
I've opened something which would help also. Am I being too lenient?
No, it's
A
fine.
bit.
Let it be on.
All right. As long as we're learning something, I'm having fun. I'm also learning few things. So Anne Marie, and after that, Fiona, just be ready to say anything that comes to your mind. Doesn't have to make a lot of sense, be scientifically sound, and fit in whatever we've done. Just as a non-doctor person.
I'm sorry, but I couldn't see the video. It didn't play.
Yes, best answer.
It's all right. It's all right, Anne Marie. We'll come back to you in the end. I think as we speak, Anne is
I'll
trying
send
to
her the
send a
video.
video, yeah, personally.
Yeah, that's a good
Fiona, do
idea.
you have anything that you want to say?
The doctor could have been more empathetic towards that girl's mother rather
In
than
the
getting
beginning or in
angry
the
at
end?
her.
In the beginning or in
Both
the end?
times. Both
Both.
times.
So in the beginning, she sounded quite empathetic, to be honest. I thought she was good in the beginning. I don't know what happened to her in the end when she lost it completely. What do you think went wrong towards the end? Why was she getting irritated? I mean, she started off okay, no?
Yes. But towards the end, she got a call in between. The ear was busy. She could have
Yeah,
taken the mother to a little more calmer place and could have
yeah,
spoken
yeah.
with her.
Yeah. So my belief, I agree with you, man. My belief is that Anne is a good doctor, very empathetic. I mean, not Anne, the other doctor, and she wanted to, but I think sometimes, no, I mean, I'm a good human being, but if there's too much chaos, I become irritable and angry. So it just confuses my brain, and the way when I'm confused, I don't say I'm confused. I just get angry, and many of us do that. So, like you said, I think fantastic. Can we give a round of applause? This is the least we can do. There. So we've given the other Anne can also give a round of applause. She heard this, so it's good. Nice. Super. So the main thing was just go away from that noise, clear your brain, because if you go away from the noise, empathy will come more easily from your system. All right. The next we have is that was Fiona who answered, isn't it?
Yeah.
Yeah.
Thank you, Fiona. So Anne is still looking at the video. Can we have either Julia or Jyotika next? Just whatever comes to your mind, like this. Julia or Jyotika, whatever comes to your mind, man. We're happy to.
Did you guys actually manage to see the video? I think
Sorry,
some.
sir, but for me also the video is not clear. Maybe my network
Oh.
issue, but it's not clear for me.
I'll send it.
Could you hear the thing? Could you hear at least, if not see?
No, sir. Even the video, it was like bits and part. I couldn't follow the
No
video
problem.
also, and I couldn't hear anything.
No problem.
Can we
Okay.
can we put the video into the chat box so that they
Yeah,
can
yeah.
watch? Yeah.
Yeah, because this is important. No, the real learning is happening here.
So sorry, Moses.
let me-
And just forward the video into the John Knight Academics group. So it's
doing
that's
both.
our group.
I'm
And
doing.
then people.
I've sent it on.
Yeah.
I
I've
think the
sent it
reason we are
on.
doing both. Yeah, I think
Oh,
the
it's
reason
the
we need to do this is the real learning, to be honest. We've discussed a few things, which is good, but if now we all can share with each other some thoughts, those are the ones we're going to remember at the end of the day. So, Jyotika, thanks, man, for your honesty. So, well done. Nathaniel, can we have any kind of comment from you if you've seen the video? And after that, Naveen.
Okay. Right. So I've sent it on the John Knight Academics group,
Okay, perfect.
and I'm
yeah.
uploading it here. So
Yeah.
you should be able to see the video.
So Naveen's okay, Naveen,
leisure.
just whatever comes to your mind, man, please go for it. It's a fun group. No one's, you can see how William is extremely kind, and so is Anne and Alex.
So, sir, what I felt is like the doctor kept saying that the child is gone, but what really happened, that was not uh, communicated properly, and a chance to see the body of the patient was also not there. So the doctor kept saying that the child is gone and she was in a hurry. The queries of mother was not answered well upon. So
Superb. Anne and Williams, any comments?
Yeah, I think it's
Yeah. She.
Sorry, go on.
No, go ahead. Go ahead.
Yeah, no, I think it's nice to just encapsulate like a small thing of what actually happened. You know, like what was the background. Like there was a road traffic accident. She came in unconscious. We did a CT, did not do a CT. The CT findings were this. If it's possible, show them the image. Explain to them, you know, this is brain, but there is so much blood which has come and it's compressed the brain. It's compressing all the vital structures. And then you tell them at this time we have declared dead, gives them or what the scene is, gives them a little bit of perspective rather than just saying that she's unwell or she's not going to make it and things like that. So build a little bit of a story of what has happened in, from the accident to the time spent in the hospital. What did you do about it? Would give you a rapport building kind of a thing with the family, so that they understand that you're taking them seriously and you're not just doing some rapid, okay, I've got 30 seconds, I'm telling you this and I'm out of here. So I think that's a good spot, Naveen, if I've got your name right.
Yeah. And Anne, any points? What he said something very specific. No, I was quite impressed.
He kept saying that she didn't say dead. Moreover, she said gone.
Gone.
That, and then wait, what was the other part? Sorry, I was trying to send the videos here.
No problem. But I appreciate that he picked up that Naveen picked up the gone pit. Okay,
I think
Teresa.
can I weigh in one more point? So when we say like people, it's very difficult to use the word dead. There's a lot of hesitance towards it. And
Yes.
In English, we've been trained in Bangalore, and we all are from different states, from different language backgrounds and different cultural backgrounds. And these bonders are doing their work in different parts of India. So I worked in Kerala, and one difficulty that I faced initially was how do I say dead in the language, in a way that is very acceptable, or that can, in a way that I don't offend them, but I communicate rightly, and how to say that was important. So I think for all you bonders, it's important to find out the right phrase or the right way in your language that you can say that might, even in Kerala, from different points of Kerala, it can vary. The dialect can vary. The way they put it can vary. So it's nice to be aware about how they do things there. So what I really like the point that one of our speakers brought in. See, look at your nurses, the senior nurses. They have been there. They have done this many times. So initially, when you're starting off in your bond center, listen to them and bring them also along with you. Don't go alone and break. Don't be a hero. You can't do that. You're starting off very fresh. So bring them along with you, and then you both like can work your way towards like breaking the bad news. That's one thing. Yeah, that's one thing I wanted to say. Yeah, Murtaza.
I think he wants
Yeah,
to
yeah.
say something. Alam.
Yeah. Sorry, just to add to that, this is a problem, cultural sensitivities and what words people understand well. But just like they say, happy birthday is happy birthday in any part of the world. For when it comes to death, the way you do it may be different, but the word death certificate, a declared dead, somehow tends to go well in most contexts. So you say, in whatever language what is it in Malayalam, Marandupoi, what is it? Sorry, not Marandupoi, Sattupoi. Sattupoi.
No, that's
Okay, for
Tamil.
example,
Tamil.
okay, so you
The
say
problem
something
with
like that.
Sattu is it's a not right. It's not
It's
not
appropriate
the
word.
right.
very
So
Yeah.
you say
informal.
ആള് മരണപ്പെട്ടു അല്ലെങ്കിൽ ആള്
Yeah.
മരിച്ചു. The way
Okay,
you put it.
yeah, so you try to say
Don't-
something like that. For example, you say Marindapattu, whatever. Okay, after that, they're still confused, whatever, and they don't get the point. The second time, you can't keep saying the same thing. You say, see, I'm really sorry. I've discussed this with the other doctor and the in charge nurse. We three believe there's no use, and we have declared the patient dead. We've declared the patient dead. And what I do when people don't understand, and very, very often I get patients in Maharashtra, Karnataka, they just don't get the point. I say, we've declared the patient dead. 12:45 is when we've said the patient was dead. Somehow that, because of the movies that we've seen, that strikes the point. Oh, this means, oh, he's actually dead. Then people say, oh, he's dead. They're like, yes. And I say that we declared the time of death as 12:45. Somehow that strikes. Against all languages, that works. So
That's
just
also a good thing. Yeah,
it
time
works
of
because I've done this. So last 1.5 years, fortunately or unfortunately, I've been made in charge of an ICU and an emergency department, and there I had to do this regularly. And so I figured out this tends to work. So just a thought, do it in your own way, but always remember there are certain key things like a watch. So that's one of the reasons I always wear a watch, because I can show them and I act. The time of that was 12:44, and they get that point at that point.
Yeah, another point that I wanted to reflect on was William said, give them a context, tell them how what happened, and bring in CTs and stuff like that. So this is just my I'm just reflecting, so you can correct me if I'm wrong. What I used to do in my bond center was just to so before so what my senior doctor taught me there was don't break death at just one go. Visit the family multiple times. Like go tell them tell them it's a critical situation first. You give them one shot, then come back and stay with the patient. Try what you can do. Go back again in few minutes time, and then slowly set the mood and then break. That's what my senior told, and I found that really worked well for me. Another thing is so if you have time, if the patient was brought in sick and you have moved the patient to ICU and you are attempting CPR, then this strategy of going again and like coming back and slowly breaking it makes sense. But if you have a patient who's brought dead, or something like that, where you don't have that time to like go in again and come back again and do that thing. If you can instead of like giving them everything that you know, giving them all the background that you are aware all at one shot to them, it's nice to check their understanding in the beginning, to talk to them and ask them what exactly happened. This is that's the style that I've been mostly using. So ask them what exactly happened, and then check their understanding, see where they are standing from their perspective, see how much they understand about the seriousness of the issue, and then from there on you will mostly get a room to build on. That's what I felt, and that's what that's what I have used. But I think yeah, so yeah, anything more to add
Yeah.
on, you guys? Yeah.
Yeah, exactly. So the whole getting information from them and all of that, it all comes under that one mnemonic called grieving. And what I think bonders and junior doctors could do is, I don't think it's ideal that you should keep that at the back of your mind and be like, okay, gee, this is what I have to do now, or this is what I have to do now. If you get maybe just 5 of them for the first time you're declaring death, at least 5, then that's fine. And then slowly you build, because this again is not something that you have to master at the first death you're declaring. It's a skill that you'll slowly develop, but you need to develop it right, because if you don't, and if you continue to do something wrong, it's difficult to change from that. So try picking small bits where, if you remember maybe 5 of the I don't know how many letters there are, I've not counted, but maybe 10 letters. If you've remembered 5 of them and you've used 5 of them, give a pat on your back, because you've done something better than you did before. So I'm sure on Google, or if you could just, I'll put it on the group as well, the mnemonic, you'll find it on Google. You just need to type grieving Tintinali and you'll get that mnemonic. Try using it once and try using it very naturally. If you don't get all of them, it's okay. But start practicing this way. It'll help you and it'll make things better also for the patients
That's
and
a
the attendants.
fantastic point here. That's a fantastic point. Not aiming for perfection. Just start getting on with the job rather than thinking of a perfect thing and not doing anything. Because when you try to look at the perfect picture, it's going to take years, and for that, then you won't start. So fantastic point, man. And just quick to check with Teresa, if you've got your thoughts. Anything you can say, just about anything, Teresa. You can complain about the British weather. We are happy to listen, or you can talk about the video that you saw.
Um, just like everybody mentioned, the setting was not great. It was very noisy, and then there was no clarity in the communication at all. As in, the doctor did not explain the diagnosis. Used words like "gone" instead of clearly mentioning that the patient had died. Those were the few things that I initially noticed. Yeah, that's about it.
Okay.
Something yeah, that's fantastic. Did you notice something else that is considered very unprofessional, considering you're in the British setup now? Something very inappropriate, apart from the obvious blaring things about the setting per se. Something about
I did not think answering that call in the middle of that conversation was I wouldn't have done that.
keeping your mobile phone on silent even before you enter this conversation, because you know you're entering this conversation. You didn't come flying in. You knew this was going to happen. So mobile phone on, because I'll tell you the funny part. Literally, this has happened with my postgraduates. This is despite telling them, when we are going to declare death, I'd like the phones on silent. Obviously, exuberance of youth. One of my postgraduates didn't do it. He just thought it's a checklist that this guy keeps talking about. We went in to declare death. It was very difficult because it was a young kid. The mother was crying like crazy, and this man's phone had the bloody ringtone of "My name is Sheila." Can you imagine? Here I am, my hand is literally on that lady's arm, trying to stop her from sobbing, and she's making my shirt wet. She's crying, and this guy's dinchik, my name is Sheila. Just so awkward. He got the dirtiest look from me. I haven't done that in a long time. Like literally, he must have skipped a beat just with my eyes, because I was so upset with him. It broke everything that I had built, because I knew that was going to be a difficult one to break, and I knew the family was beginning to mob, and I wanted it perfect. It just went off because of one bloody Sheila. I'm not Sheila, but one bloody ringtone. So simple. It's all some things you prepare. So before I walk in, I do this, and people think I'm crazy that every time I say before going in, I'm checking everybody's mobile. 3 of you, 2 PGs, one nurse. I want all your mobiles on silent. So it's small things like this, but they add up to something. Reduces my stress when you're actually doing something stressful. So fantastic
I think,
point.
Nathaniel's got his hand up. I think, does he want to say something, or was that by accident?
Oh yeah. Yeah, actually, there's one thing I mean, I just saw the video now and then put it up on the group. Another thing is, he was just like, I think he's gone. I think we can't do anything. She was not very, very confident about what exactly she's trying to say.
Yeah.
So when you're in a situation like that and you're just like, I think, I don't think that like really goes, I mean, is a good way of communicating with the attender. Another question I would, yeah, another question I have for all of you all is, like in certain situations when like they're really sobbing and all of that, is like physical touch, maybe like a pat on the shoulder or this thing is that like okay, or is that like a good way of empathizing with the attenders?
I think you need to read the room very well before you make physical contact, especially in India, because there are a lot of cultural connotations to it. So I know where you're coming from when you want to do it. If it's same sex, then I don't think so much about it. But if it's the opposite gender, then I would think twice, because you want to really assess what you're delivering, who you're delivering it to, and then take a judgment call on it. I don't think, in my practice, I don't think it's mandatory. I think your words, your behavior, your facial expressions, how committed you are to those 5 minutes that you're spending with them are more than enough. But I know I've seen people do it, and I think it's a personal thing. But for me, it becomes very, very, it can become a slippery slope if it's not done well, or if your situation's not right. So for instance, I'm making this up completely. If you've had a young chap dying and his young wife's coming, and then you're delivering the news to her, I would think 200 times even before I go anywhere without it. As much as noble your thoughts are, you're also dealing with a very stressful situation. So that's my personal take. I know others would have their say, so I like to hear their opinion as well.
If Anne doesn't have anything to say, I'd say something here. Definitely want to say something here.
You, Deja, go ahead. What is it?
No. If Anne, that's why I said if you don't have anything to say, but if you do, it's after you. After you.
No, go ahead.
Okay, so this is where the thing is. It's like graded. When I lack confidence as a junior doctor, I would have never even thought about touching a female, especially if she's young and maybe rural background or whatever. With time, as my confidence has grown, and I've realized through a lot of maybe therapy even the value of touch and what it does to people, I've slowly become more ambitious to challenge myself. Can I also do this when it may be a bit risky? And I've done it about 6-7 times. I know against the rule of what the house is telling me. I've done it, and it's, to me, it's worked. It's also because there are two things. One, I always have a nurse by my side. Second, I build rapport with very, very good eye contact. And before I make any kind of physical contact, I start moving in a bit closer. So like literally, I'm sitting and declaring, so your child, this happened. Yeah. But we all did whatever we could. And despite all that, the child did not recover. And so we all had to declare dead. So when I've done that, I've changed my tone. I've come closer. I'm testing the waters. When I come this close, if that person doesn't even flinch a bit, it means they're comfortable with that much. Then I know where to touch. That's very important. So the hand is very sensitive. I would never touch a young lady's hand. But the shoulder is not too bad. And again, it depends on what comes naturally to you. To me, it comes a bit naturally, to be honest. I'm a huggy type person. Somebody like William, imagine I'd really hug him each time I see him. I don't know if he likes it or not, but it's just it comes naturally. So I won't hold it back. I give a very gentle tap on the shoulder and then reassess. Did it go down well? If it did, then I'm okay with both shoulders. It's like, it's okay, it's fine, it's okay. I let them cry. I don't speak. I just hold. The moment I sense something is wrong, I take a step back. Rarely will anybody think because they can. It's all obvious in my body language. I mean good. So, but this again, like William said, you need to assess one, the situation around, your overall confidence with what the hell is happening in your department, and your comfort with touch. So I'll just give a quick example. In the old MRCM guidelines, you get 1 point for appropriate touch. You get 1 point for silence when the person is crying. Okay. So when I was practicing this with another guy, very awkward chap, he literally used to do the touch with me. I was the patient and he was, in a very awkward way. He used to literally come and try to hold me here. I'm like, dude, what are you doing, man? You're just trying to gain 1 point. So it didn't come to him. So he's better off not trying it because it's not natural. For me, it was just natural. Even in my exam, there was a young girl crying. I went and actually held her because I felt it came to me naturally. So I'll leave it at that.
Another thing I wanted to add to this whole thing is something I've noticed in the ED while I worked here for the past 1 year is that everyone shows that good amount of empathy when they're breaking the news and they've told the family whatever needs to be told, and they've offered their condolences. And so then usually the ones who break the news are in the red zone. So these guys come back and they're immediately back into their zone of treating the more critically ill patients and intubating and shifting to the ICU, negotiating with ICU and all of that. Now comes the part where these attenders are going to come back to you, and this is probably the time you've given them to grieve, as well as you've given them time to get information, gather information, and decide what they want to do further with the body. And at this point, if you change your entire stance where you're in your zone, you're like, okay, I have finished my job of breaking the news. Now I'm just going to do my work. And they come back to you, and now they're asking you for doubts, and they've asked you something which they want to clarify. And you're being very indifferent about it, or you're being very snappy about it. It's two different people they have seen now in the past maybe 5 or 4 hours. And that's very confusing, and that's very off-putting also for them. So that's also something which is very important, that you need to maintain that stance throughout, and be very, calm and patient with them with all of their doubts until they have finally figured a route which they're going to follow, and until they're satisfied with the care. I think that's the completion of the whole thing, rather than just, at the point of you've declared everything and you're done with them crying and, giving them that amount of comfort. So I think that's also very important.
Fantastic point, man. And that continuity, it's not just one thing. It is a continuum. And so you need to, what they say is in lots of books and lots of places where I've worked, switch on and switch off. That's our job, man. You're switched on the emotional part. Now you're switching off because you're doing a CPR. You can't be emotional in that. You're just logical. But again, you need to switch back to the emotional. And this is just awareness. As long as you are aware that you need to switch on, switch off, it will happen. As long as you are aware that I need to switch on, switch off. Literally, I tell myself to switch on, switch off in my head. I seem like a nut on the shift, but I do that and it makes it easier with time. So yes, I'm very keen on listening to Jyotika. Jyotika, everyday poi.
She was one of my favorite
Hi, sir.
interns.
Jyotika, parada.
Jyotika,
Sir,
you don't
about
have
like,
to speak in to Murtuza.
hello?
You don't have to speak
Hi,
in
Jyotika.
Malayalam back to Murtuza.
No problem. I'm talking English only.
Okay. No, even Julia, we haven't heard from her. So both of them, and then we can close if no one has any other points.
Sir, I think the whole setting of the like the breaking the bad news was wrong, as others pointed out. Like it was very crowded, and also like she was like initially telling that the mother that the child is critical, and then immediately jumped into she's gone, and just she's not explaining anything like what happened to her. It's just like she's emphasizing the point on like she's gone. That's the only thing that she's telling. And also she's not giving her any time to process like what she just told, and she's just moving on to her duty as usual. Like she's not empathizing with her at all. Like it's part of her duty, and just she just told that, and then she's just looking after other patients. And then when the mother is approaching her, and then she's again back to the being rude and not explaining anything at all. And I think it's really bad than not telling anything at all, because like if you're not telling it properly in the first place. And also like what happened, like it's a more than anybody, it's a young child, it's a 19-year-old. So after everything the mother has gone through, like to break a news like that, it's really bad, I felt.
Yeah, I think Merin actress in this whole play. She's the doctor, Merin, and we did only maybe 2 takes of this entire thing. And by the third take, she felt so uncomfortable doing this entire skit, even though it was just a play. She's like, no, I don't want to do this. It's okay. You somehow fix these videos together and then just put it together for a video. I'm not doing this again. It's just
Wow.
really weird.
Wow. So I've done a leadership course for 10 days and they made us do things like this. Can you believe it is just a role play? And I was with 35 mature people under the age of 35 from across the world, some of them working in big political parties and things like that. This happened with us. People started crying. I was like, it's a game. And people started crying in the game and started getting upset, started fighting. We were playing a game
Yeah.
of, rich countries giving money to the poor countries. So this happens. I mean, just imagine if it can happen to 2 actors. It's a good point, man. Fantastic point to bring up. Wow, superb. Julia, can we hear from you?
Hello.
Okay.
Hi, Julia.
Hi. Right. So one question I had was, would everyone take that empathy part as comforting, or like if like it's a sudden death? So sometimes maybe they won't take the empathy part as it is. Like they'll be like, "What do you know? You don't know anything," and then become violent very fast.
That is.
So I think the thing is, no, I think it's a good point because I think whenever you're delivering news like this, whether it's breaking bad news or whether you're even giving a bad diagnosis, it is very important to read the room and see who you're speaking to. A lot of times, I think it comes with practice, it comes with experience, and you'll start noticing it as soon as you're in these situations more. You'll realize which family is going to reciprocate what you're telling them, which family is really upset with what has happened, and which family is really angry with what has happened. And all of these are very acceptable, what do you call, reactions to something. So it is not all hunky dory where you just tell them and everyone's so nice, oh thank you for trying. There are people who say that, what did you do? They might just say that, I think he's still alive. Very random things like that will also be said. So you need to be able to gauge the room and then deliver your speech accordingly, using very flowery English or whatever language that you're using, that saying things like, I totally understand what you're going through. Now what does that mean? If you're telling a 40-year-old man that his 3-year-old child has died, and saying things like, I totally understand what you're going through, I can feel your pain, I understand what's going on right now, all that does not count, because that is you just saying random English without you even in any scope of the world trying to actually empathize with them, but you're saying some token statements that are that are fed by you through books and things. So when you're empathizing, you're just trying to show that you're giving them your time and attention of that 5 minutes, that for those 5 minutes you're my only priority, and I'm telling you everything in the most humblest possible way that I can. That is it. It does not mean that you have to say, like, very nicely you're saying that, "Inke ella manslavunnundu, I know it is so bad, life is unfair," and bullshit like that. Okay, so all you're saying is, see, this is what has happened today, this is what has happened, this is the time that we've declared death, and then you just be silent. You don't have to keep filling in things to make the awkward silence go on. Just let it be silent. Let them process the information their loved one has died, or they've got a really bad diagnosis coming up. Give them, they might want to scream, they might want to shout, they might want to just be in silence. So you let that 30 seconds, and I'm telling you that 30 seconds will be the longest 30 seconds that you've ever had, because the temptation to say this bullshit is so much. You want to fill that awkward space with some nonsense that, oh, so sad, the other day we had another case like this, or some nonsense like this. So you just want to stay quiet and let it be, let them process it, and then you again read the room, like how Murtaza said, that you've got the physical aspect to it, or you just stay quiet and let them say something, and then you take that conversation in the direction they want to say. They might say, in my role to make that happen, let me just quickly see if we if everything is okay, and I'll come back and get you. Feel free to use the room or whatever, and offer water or whatever, something like that. So I
Yes,
think what
yes.
you picked up, yeah.
Sorry,
What
sorry
you
to
picked up
interrupt.
about the empathetic topic is very important, because I think we've used the word empathetic today 55 times. I don't know what it really means. The other word which we say is putting yourself in their shoes. I do not know what that means either. Okay, so you really can't when you've not had
Because
that
you're
experience.
Malayali, you anyway chappals, man.
Oh,
Oh,
yeah, true. That's true.
No,
So
but sorry,
does that
sorry.
answer your question,
It does, man. I think it's fantastic what you've just said. I think it's making me think, wow, that's 30 seconds will be the longest 30 seconds of your life. Sometimes the best you can do is just shut up. It's so difficult, man. It is difficult. And I've done this mistake, by the way, fill up with gaps of trying to do all these rubbish things. Just a quick thought on a couple of things now. I have one thing to discuss, but this all depends on Alex and Anne. If they say we have time and energy, we do this, or we just call it a day. To ask if the family is insisting, no, please try, doctor, please try. കുറച്ച് ഇന്നു 2 minute try ചെയ്താ മതി എനിക്ക്. So if they say that, what would you do? Can we discuss that on another day, the next round? Because have we run out of time? Because I also have another thing to add. I wanted to end on a positive note. If anybody can say one good thing that those two doctors did in the video, at least one good thing, I'm willing to give them. I'm willing to give them a Kiss Me Toffee bar. It costs 25 paise or 50 paise, man. But it's so
I
difficult to
tried
achieve.
to make, so I don't know what you're going to get. Like Merin kept doing things right. I'm like, no, this is not what you're supposed to do. Do this instead. So I don't know I have to look at this video now.
Maybe she made sure at least the relative or the mother was seated. That was good.
Wow,
Yeah.
Teresa, you're going to get a kiss.
I've got something to add to that. So I've been actually itching to say that, but I think there was a little bit of a mistake there. I'm really sorry. I didn't mean to jump on your feet there. But as much as she offered the seat to the family, which is really important, which you have picked up on, I feel the doctor should also be seated, so that you have a parallel discussion where you're like this, instead of coming from this position of power or strength, where you're trying to say that, listen, you listen to what I'm saying to you. So I think it's very important to offer them a seat, but also have a seat for yourselves where you have a conversation where you're coming from the same position, if that makes sense.
Fantastic discussion.
That's exactly what I'm trying to portray over there. The standing and sitting, that was something we were trying to portray over there.
Yeah, so the take-home message is not that everyone should be standing. The take-home message is that everyone should get a seat.
Seated, yeah. But good job, Teresa. You almost won yourself a chocolate, but William stole it. So I'm sorry. I'm sorry for that. But just one last thought, if you want to do this, or we can just do it later, is what do you do when somebody says, doctor, and self try my doctor, please, doctor, or somebody like, in Malayalam, 2 minute, please, what will you do? Try.
I think maybe we should do this now, as there's a flow. Just maybe 5 minutes of this. Will it take more than 5 minutes? Or
it should
very
not
long?
Take more than 1.5 minutes
5
only.
is too much.
Yeah, I think because we're in the topic.
Okay. So who's going to tell us what do you want to do? Somebody says, please selpa try madi.
I wouldn't try.
I'm just reflecting what I did as a bonder. So once I've told them that it's no more, and they've declared death, but they're still telling Salpa try madi. I think that this is where silence comes in. So would give them their time. I would go back in. I would stay with the patient, but there's nothing for me to do actively. Give them time to grieve. This is the time when they process the information. That's what I feel. And I would make sure that the scene is good and clear, and I will inform my staff, let's wipe all the blood and make him ensure the patient the patient who has passed away has his dignity, and so make sure the next time when I go meet them, I would offer them, do you want to visit him, do you want to see him, so things like that. So I would use that time to set up this and then go back there again, and then offer them the sense. That's what I used to do. You can comment on it whether it was good, right, what I could have done otherwise. Yeah.
This is something that I still do find very difficult when they come back at you and they're like, this was a case which we saw in the ER. He was brought dead, downtime being around 3 hours, and they're like, no, his body is still warm. No, he was breathing in the ambulance. His body is still warm. He's still, there is a chance. I think you should try. I think you should try. And I got very uncomfortable with. I don't remember exactly how I handled myself that day, but I do remember that sensation of a little bit of uncomfortable, being uncomfortable with this whole topic, and I didn't know how to deal with it. So of course I brought in my senior immediately, and I said, "Ma'am, this is the case. I'm not able to convince them. Could we speak to them again?" So then we took them again, we spoke to them, gave them their time. Again, they came back at us and they were like, no, I think you should try once more and all of that. And I think I think 2 times this happened. And then the third time they sort of accepted it. And we went ahead with the procedure of, they finally accepted that he was dead. And they were like ready for the formal proceedings, whatever was left after that. So that was one point of time when I did find myself a little uncomfortable.
Yeah, so if William has nothing to say, I'll probably just. Okay, yeah, okay. So the thing is, no, I think what Alex's method is not necessarily a very bad idea. It's and then they get time to sort of recuperate, and it's a good starting.
Rewind a bit because you lagged a bit over there. I don't know if it was just for me, but
yeah, man, I think you're not able to connect with me properly. But is the rest of them okay? Because my connection is full here.
No, your voice did break, man, for a bit.
Oh shit! Sorry, Anne, for accusing you. Okay, so I'll repeat that. What Alex's method is a decent starting method, and that's something that I've done myself, to be honest. That buying time, going and definitely not doing CPR, but like something as simple as cleaning, removing some tube or something like that, whatever it is. The problem with that is at some later point, it can be a bit risky because when you go in there to do all this cleaning business and the other doctors, one or two doctors or one or two nurses is with you, everybody knows the patient is dead. Their body language reflects a sort of relaxed, a very, very relaxed body language. Some maybe even kind of smiling or whatever. And if by mistake, the family members see that body language is loose, or they hear one of the doctors telling the nurses, "Arey, nahi, 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 they are insisting on CPR. So we're just cleaning. We're not doing anything, man. Go, go, go. You go." They tell the other doctor. Somebody hears this, you are screwed because already there's a doubt that doctors and nurses are fooling around for money. And now you're stuck from one problem that you didn't manage it competently to you didn't manage it competently and you have financial gains at stake. So you're wasting time. That's why I prefer, I mean, it's a silly thing that I do, very, very obstinate, absolute honesty. I don't move. They can say, I have felt very, very intimidated. People have like physically tried to intimidate me saying, no, no, you do something. He's not dead. We know in the ambulance this happened. I'd be like, yes, 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 yes. I know, but we have declared, the team has already declared him dead. I don't say I did it. I spoke to the other doctor, the nurses. All of us have declared him dead. Nahi, abhi kuch karo. They hold my hand. People have held my hand. No, you come right now. I'd be like, nahi, sit, sit, please sit. No, no, no. I will not move. The moment I move, I'm showing confusion. Even if I move up 1 inch, it shows that I'm not sure of what I'm doing. And it reinstates the fact that there is hope. I don't want that hope to come back. I won't move. I won't be rude, but I won't move. So that's just my point. But of course, I don't blame Alex here because beginning with when I was a PG, I've done what Alex did. Now, obviously, working in an ICU and emergency, both mixed, I'm able to not move. But it takes experience and a lot of like internal reflections to say I won't move. It doesn't make a difference. They can threaten me, but I won't move. And I know that I won't fall in trouble if I won't move. I won't be perceived as a bad doctor, loser, cheater, any of those things. I won't move. Cheers, guys. That's all from me.
I agree. I think.
Thanks, Murtaza. Thanks for that point. It was a very good learning point for me as well. Yeah.
Cool.
Yeah. Thank you. All right. Thanks a lot, guys. Thanks for the session. And anything more?
No, I don't think there's much more. Jyotika, Julia, and Naveen, do you all have any questions which you all want to address at this point? Any difficult questions at your bond centers? Anything you're dealing with that you find it's not academically related, but maybe certain nuances that your centers that you're facing at your centers that you want to clear at the moment? Because honestly, these are the two people who you should definitely be speaking to about these.
Hi, I just wanted to ask one thing because my center has more pediatric patients than adults. So when we're dealing with pediatric patients, also like is the same thing? Is this how we break the bad news? Because the parents are a bit more concerned about the child, and like do we do anything differently in a pediatric age group?
Right. So, Jyotika, my honest advice to you: are you bonding in Kerala?
No, in Tamil Nadu, sir.
Okay, not very different. Okay, so when if you're going to declare a pediatric death, if you're in a position, make sure that you're not the only doctor in the room. Okay, so how is your center there right now? Do you have other doctors along with you, or you're this whole and soul of the hospital?
Like during my shift time alone, sir, there is a pediatrician, but we are working in during my shift. It's only me. We are there's a pediatrician in my center, but won't be working together.
Okay, and at how's the acuity at your center? Is it you get really sick children, where you need to admit them?
Here, yes. The respiratory diseases is very prone here. So many sick children we admit here. I've not encountered death as of yet. We referred before that, but still, it's a possibility.
Yeah, so that's good for you to be actually here because you're aware of the possibility that things could go wrong. I don't think the principles are any different. I just feel that the discussion's going to be very intense because of the fact that a young one dying has always much more much more serious connotations for the family. So I don't think that what we've discussed, anything drastically changes, but I would say that you should not be the only healthcare professional in that room. If you don't have a doctor, like we previously discussed, get the head nurse, get the hospital administrators, whoever is a lot aware of the situation with you. But I don't think why we change anything of what we have said. It still requires for you to build up that scenario of how the patients come, what you have done, and the time of death if it comes to it. I think at a bond center, you should be in a position to refer out cases where you're anticipating such high levels of sickness. But obviously, that would depend on the situation of the child has come. If someone's crashed their car right outside your hospital, you're not going to refer them. You'll have to do something about it. So, yeah, I don't think the principles will change. My only factor to you is going to be don't be alone in that room because it's going to be a very emotionally charged situation. And it's a lot for one person to handle, especially when you're doing it for the first few times. But principles are the same. If Murtaza and Anne have anything else to add to it, I'm all yours.
I just have one specific thing. So there are studies proving that a witnessed if the parents of the child are able to witness the resuscitation, it helps a lot in them accepting the death. So traditionally, you would believe that when you're doing CPR or whatever you're doing to the kid, you want the kids to wait outside, parents wait outside. But no, you want them to see the CPR. Okay, as much as you think it may traumatize them, but actually it does the opposite, and this is study proven. For adults, the results are questionable. Some say yes, it made a difference. Some say it didn't make a difference to the family. But pediatrics unequivocally proven that having them witness the arrest helps in breaking the news. That's one thing. Second is, of course, the build up where you make them. So I wouldn't just run through the history. I would make them say, so before you brought the child here, the child was not breathing, correct? Or was breathing very poorly. Okay. Was the child at least saying some words? Oh, okay, not saying words. So you're saying the child was not saying any words. Oh, okay. So, you're repeating it. You're making them say, you're saying that the child was not even saying words. Was the child moving all four hands and legs or hardly moving? Oh, child was hardly moving. So each of those things is reinforcement. So you're saying this, you're saying, so they already get the point first. and then you declare this death after you've resuscitated, preferably in front of the patient's relatives. The other caveat when you're dealing with pediatrics deaths is it's like a bit of an anxiety triangle. What happens is if you have a lot of extra people in the family, they tend to make the parents more anxious. So very, very important to get rid of the useless people. They'll sometimes have some useless neighbors, this, that. Get rid of them because they have no role in this except to increase the anxiety. Stick to the two closest relatives and only declare it to them, because the other one will probably create confusion. So these are the 2-3 extra points. I think it's also comes down to your confidence and to the purpose you're serving. If you see that the child is already arrested, brought dead, I would not refer them for the fear that they'll, something could have been done or they'll break down the hospital. You be honest to yourself, be confident, take a sip of water, nice deep breath, go confidently and declare death, because it's not fair you're referring a half dead or dead child to another hospital just for declaring death. So I think they'll be happy with that you've saved them some money, effort, and you've been honest. But again, depends on the confidence you have in yourself, the nurses, and the system, how much the system respects you there. So it'll come. Keep trying. Cheers, man.
I think this whole CPR in front
Thank
of the
you.
parents, I did have this same experience where I had a 10-month-old child who they took a discharge against medical advice from a nearby hospital and brought her here. She was already in a really bad condition over there. The doctors over there weren't expecting her to make it, and they came around 3 a.m. in the morning. And she was already unresponsive, no pulse. We started CPR. Family was there. We don't have a enclosed um, emergency room. So it is kind of open. So the family was there. We're giving CPR, gave, I think, maybe 10 cycles we tried because 10 months, and I didn't want them to feel like we didn't do anything. And then we declared death, and I was so scared. I was shit scared that night. Declared death, and because it was 3 a.m., couldn't get any senior doctors. Nuns weren't available, and I was being a bit of a hero, which now when William said that, I think it's a very good thing to have someone senior with you, whoever it is. Declared it. Luckily for me, on that day, they accepted it, and nothing wrong happened, or nothing grievous happened towards the hospital or towards me, or even they sort of felt very calm at the end. So this whole CPR thing just brought that memory back to me, and I just wanted to share it across. What about you, Naveen? Do you have any questions before we wrap this up? Is Naveen there?
No, I had a question, but then Murtaza sir already answered to it. So
Okay, all right. He read your mind. All right then. So if anyone has anything to add before we end this call, I think we've already overshot with time also, so we can end this
A
call.
little bit, yeah, but it's okay, I guess. Yeah.
Yeah.
It's been a brilliant discussion. Thank you, and thank you, Murtaza. Thank you, William, for taking your time out and joining us for this. We will get this recorded version of this class into the alumni page as soon as possible. So a lot of the bonders have already messaged me. They couldn't be a part of the live program as such, mainly because it's a Saturday. Many of them are still working, but yeah, they'll definitely benefit from the discussion that we had and from the beautiful class that you organized. Thanks, Anne.
Thank you so much. Thanks, Alex.
In the interest of social media gimmicks, can we have everyone's video on so that you can take a screenshot of this? Oh, so that you can, if you're sharing it with somebody, so if everybody else's videos are on, it'll be nice. But if it's not, it's okay. I don't insist. This is because this is what people expect these days. I'm not a usual social media person, but if you can, it'll be nice. But you can take a screenshot and share it. See you guys. Bye-bye.
Bye.
Thank you, guys. Take care, man. Take care. Bye.
Bye.
Okay. Bye-bye.
Bye-bye. Thank you.
Bye. Bye-bye. I shall bid everybody farewell.